Hello, everyone. I'm Dr. Supriya Mannapali, Medical Director for Infection Prevention and Control at Northeast Georgia Health System, Gainesville. I thank you all for this opportunity to share some information about measles, current state, and focus on prevention. I do not have any disclosures, and I'm going to start off with a case. 22-month-old female presented to the emergency department with complaints of fever, congestion, cough, and feeling unwell for 2 days. Other siblings were also sick with similar symptoms. Rapid strep antigen, COVID, flu, RSV PCR were negative. So 4 days later, the child presents back to the emergency room, but this time the child had a rash. And the rash started on the face and progressed down to the chest and arms. There was no conjunctivitis or any lesions inside the mouth. The child was dehydrated, needing admission. And the measles test was positive from the Department of Public Health. If we look back here, the second time the child presented, there was more detailed history obtained. The vaccination status that shows the child was unvaccinated for that age. And also there was recent travel. These two increase the risk of a possible infection that the child contracted during the travels and also is susceptible to because of the lack of protection from the vaccination. Also, because in measles, the rash appears later than the fever. So the second time the child presented, there was much clearer presentation. And with that detailed history that led to the diagnosis of measles based on a PCR test that was sent to the Department of Public Health. If you look at the current state in US in 2025, and we're now coming in mid-May, there have been more than 1,000 cases, and 30% of those cases were in those under 5 years, and 38% in those between 5 to 19 years of age. And if you look at the vaccination status, 96% of the measles cases have occurred in those who were either not vaccinated or their vaccination status was unknown. 13% of these patients actually required hospitalization. And percentage of age group hospitalized, if you look at that here, it's the children under 5 years at 23% that required hospitalization. And there have been 3 confirmed deaths among those that have been detected to have measles. So again, more than 1,000 cases this year, and the count continues to increase. And this is very concerning. And in the next few slides, I have some more details about where most of these cases are occurring. If you look back at 2024, for the entire year, there were around 284 confirmed measles cases in the United States. And 42% of those cases were in those under 5 years. And again, coming along the same theme, 89% of these measles cases were among those that were either unvaccinated or their vaccine status was unknown. And 40% of these cases required hospitalization, either for management of some complications related to measles or for isolation. And 52% of those hospitalized were under 5 years of age. And measles became a nationally notifiable disease in the United States in 1912, requiring US healthcare providers and laboratories to report all diagnosed cases. In the first decade of reporting, an average of 6,000 measles-related deaths were reported each year. In 2000, it was declared that measles is eliminated in the United States. But we continue to see these cases, especially in communities with low vaccination rates or among those who are not vaccinated, or in those who have traveled to an area where there are measles cases still occurring or as part of an outbreak. If you look at this graph, it shows how there was a sharp decline in measles cases in the United States after the availability of the vaccine. And that's very, very important to recognize that while there is no specific treatment for measles, when the infection occurs, the main thing we can do actually to prevent measles is vaccination. That's our strongest prevention. to prevent measles from spreading. And measles is extremely contagious. 9 out of 10 susceptible individuals that are exposed to somebody with measles will develop the infection. You compare that to, let's say, COVID. We all just recently in our memory just got out of the COVID pandemic, right? The intense phase of it, even though we see COVID cases still. One measles patient can spread that to 1 or 2 susceptible individuals that are exposed. But with measles, out of 10 that are exposed, 9 of them will develop the infection. If they're susceptible to the infection, they don't have immunity. So that is something very important to recognize, that measles is extremely contagious, and the only way to prevent the spread is to have immunity. And to develop that immunity, what we have is the vaccination, which is very, very effective. And if you look at the measles cases over years, and this graph starts from 2000, when measles was declared eliminated in US, we have continued to see some clusters, especially in communities with low vaccination rates. And 2025 is still not over. And if you see here, we may be surpassing this tallest bar here that was kind of just before 2019, because we're already at more than 1,000 cases, and we're in May still. And if you look at where these cases are occurring, if you see this, that's Texas, that has had more than 250 plus cases, majority of the cases. And then there have been some other states, New Mexico, Kansas, North Dakota, that has seen more cases. And of course, here is, you see Georgia. We have had measles cases as well, but we're in this light blue region, which means we have had 1 to 9 cases in Georgia. And as I mentioned, the most powerful tool we have to prevent infections is through immunity developed by the vaccinations. And if we look at the vaccination rate among kindergartners by school year, if we look here for 2023-24, 88.4% of these children were vaccinated for measles. And to develop herd immunity is where we have enough people in the community that have immunity, either by vaccination or infection, but primary vaccination, so that even if someone develops an infection, there is that ring of protection around those who may be susceptible, who either are too young to get the vaccine. These are children before they're eligible to get the vaccination, or those who cannot get the vaccine due to contraindications, because measles vaccine is a live virus vaccine. So if we have more than 94% of people vaccinated in a community, that creates what we call as herd immunity, so that the infection does not travel as fast or spread as fast. And in Georgia, we're at 88.4% vaccination rate among kindergartners for the school year 23 to 24. In the decade before 1963, nearly all children got measles by the time they were 15 years old. It is estimated that 3 to 4 million people in the United States were infected each year. And there's also some thought that maybe the cases were underreported. And among the reported cases each year, an estimated 400 to 500 people died from measles complications. 48,000 were hospitalized and 1,000 suffered encephalitis, which is what we call as subacute sclerosing panencephalitis. It's swelling of the brain, and this can actually present later on, but measles itself can cause encephalitis as well, which can occur as part of the acute infection phase. But there is an entity called subacute sclerosing panencephalitis that presents many years after the acute infection due to some changes in the brain caused by this reactivation of this latent virus. And measles vaccine. I think it's very notable and important to mention that in 1954, John F. Enders and Dr. Thomas C. Peebles collected blood samples from several ill students during a measles outbreak in Boston, Massachusetts. They wanted to isolate the measles virus in the students' blood and create a vaccine. And they succeeded in isolating the measles virus in 13-year-old David Edmondson's blood. And the first measles vaccine was licensed in US in 1963. And an improved version of the vaccine began to be distributed since 1968. Measles vaccine is either combined with mumps and rubella, what we all know as MMR, or can be combined with mumps, rubella, and varicella, what we call as MMRV. And after somebody is exposed to the measles virus, it takes 7 to 14 days after the contact with the virus to develop the symptoms. And that's called incubation period. And usually the initial symptoms that a patient experiences are fever, cough. There can be some runny nose or coryza, or red watery eyes called conjunctivitis. The 3 C's: cough, coryza, conjunctivitis, along with fever. These are the initial symptoms. And that is then followed after 2 to 3 days. We may see these white spots inside our mouth in the buccal mucosa called Koplik spots. It's very important that we look inside the mouth and see if there are any tiny white spots inside the mouth 2 to 3 days after the initial fever and other symptoms begin, because these are very pathognomonic for measles. And these are some other pictures of those Koplik spots. These are the white spots that we see inside the mouth on the buccal mucosa. 3 to 5 days after the initial symptoms is when the rash starts. That's why if you saw in the case that I presented early on, when the child first presented, there was no rash, there was fever. But then later on, after 4 days, when the child presented, there was rash. And the rash appears 3 to 5 days after the first symptoms. Usually begins as flat red spots, usually on the face, in the hairline, and then it spreads downwards into the neck, trunk, arms, legs, and feet. It's usually maculopapular, which means red spots that can be raised or just confluent red areas, and usually spreads again, as I mentioned, from head to the rest of the body. And when the rash appears, the fever may spike to more than 104 degrees Fahrenheit. And these are some pictures of the rash. You see that red confluent areas and raised, so maculopapular, morbilliform rash. And I got these pictures from the CDC website. Here's some more pictures of the rash. Here again, some more pictures of the rash. And complications. Again, as I mentioned, the children who develop measles can have various different presentations. They may be dehydrated, requiring hospitalization, like that child in the case I presented early on. They may develop measles pneumonia, or they may develop encephalitis, which means involvement of the brain. 1 in 5 unvaccinated people in the US who get measles need hospitalization. And as many as 1 out of every 20 children with measles will get pneumonia, which is infection of the lungs, which is the most common cause of death from measles in young children. 1 out of every 1,000 who get measles will develop encephalitis, that's swelling of the brain, leading to deafness, seizures, disability, and death. Nearly 1 to 3 of every 1,000 children who become infected with measles may die from respiratory or neurological complications. And if those who are pregnant develop measles infection, this can lead to prematurity or low birth weight babies. And the long-term complications, very, very important, subacute sclerosing panencephalitis. It's extremely rare, but fatal disease of the central nervous system. Usually develops 7 to 10 years after a person has measles. Even though the person fully recovers from the initial illness, suddenly 7 to 10 years later, they present with neurological symptoms. And the risk of developing this is higher for a person who gets measles before they're 2 years of age. And it's thought to be encephalitis, which means infection, inflammation of the brain, secondary to reactivation of the latent virus. And these are scans imaging showing some atrophy, increased signal in the brain white matter. So measles, to summarize, is an acute respiratory illness with fever, followed by rash. So fever starts first with cough, coryza, which means runny nose, conjunctivitis, red watery eyes, and then the Koplik spots, which are the white spots in the buccal mucosa, and then the rash starts. Rash always starts head and then goes down. And the incubation period for development of symptoms is 7 to 14 days. And patients are considered contagious from 4 days before to 4 days after the rash appears. And measles virus is airborne, which means it can travel long distances in the air. And that's why the isolation precautions recommended to prevent the spread of measles is airborne precautions. And the most important, powerful tool we have to prevent infection is vaccination. And I'm going to now focus on some of the prevention aspects with the vaccination. So of course, infection control precautions by placing the patients if they're hospitalized in airborne isolation, which means a negative pressure room, and wearing an N95 mask helps prevent the spread. And vaccination is very, very important to develop the immunity. And persons infected with measles are highly contagious 4 days before the rash onset to 4 days after the rash onset. And one patient with measles can transmit the infection to 9 out of 10 susceptible individuals, so extremely contagious. MMR vaccination. The vaccination is recommended routinely for all children at ages 12 through 15 months, with a second dose at ages 4 to 6 years. The second dose is not a booster, but rather it is intended to produce immunity in that small number of people who may not respond to the first dose. Approximately 7% of people do not develop the immunity after the first dose of vaccination. So the second dose is to provide that other chance to develop measles immunity for those who do not respond to the first dose of the vaccination. About 97% of people develop immunity to measles after the 2 doses of the measles containing vaccination. And adults with no evidence of immunity should get at least 1 dose of MMR vaccine unless the adult is in a high risk group. High risk group would be someone who works in healthcare setting, who is enrolled in any educational institutions, who is traveling internationally. And so what is the evidence of immunity? What do we mean by that? Either there is documented receipt of 1 dose of live measles vaccine, or 2 doses if they're high risk. There is lab, which means we do a blood test and we see if they have IgG for the measles, which means they have immunity, or if they have had infection, because once they've had infection, they develop immunity, or birth before 1957. So these are considered as evidence of immunity. Susceptible high-risk people need 2 doses of vaccine given 4 weeks apart. And high-risk groups include school-age children, healthcare personnel, international travels, students attending post-high school educational institutions. So these are considered high risk, which means that even if they did not get their vaccines at the scheduled ages, they should get 2 doses given 4 weeks apart. So I repeat, school-age children, healthcare personnel, international travelers, and students attending post-high school educational institutions. And measles vaccination is a live measles vaccine. It became available in the United States in 1963. There was a very ineffective, inactivated measles vaccine that was also available in the United States from 1963 to 67. It was not at all effective. So for those who received that ineffective, inactivated vaccine, it is recommended that if they do not have immunity, they're revaccinated based on their risk, which means if they're high risk, they get 2 doses 4 weeks apart. If they're low risk, they at least get 1 dose of the live vaccine. If the person can confirm they actually received the live vaccine during that time era, which means between 1963 to 67, that dose is considered valid and they don't need to repeat the vaccination. It's always good to check immunity and see if they're immune, because if they're immune, they would not need any further vaccinations. And birth before 1957, this comes up often. Although birth before 1957 is considered acceptable evidence of measles immunity, healthcare facilities should consider vaccinating unvaccinated personnel born before 1957 who do not have other evidence of immunity, which means that if we check their measles IgG in the blood and they do not have immunity, they should get 2 doses at least 4 weeks apart, irrespective of the birth year, because working in healthcare setting is considered high risk. And so that's why it's very important either they have evidence of immunity or they get the vaccination. And again, this one summarizes, because there are a lot of questions that come up about, do I need the vaccine? Do I not need the vaccine? So let's go one by one. So let's start with the bottommost in this page, which is the 2 doses of MMR vaccine. So normally, if we're following the vaccination schedule, the 2 doses of vaccine given 12 to 15 months, 1 dose, 4 to 6 years, the second dose. If someone has not been vaccinated at that age and they're high risk, and we're seeing them in our office, it's very important that if they don't have any evidence of disease, they don't have any evidence of immunity based on the blood test, and they don't have any prior documentation of receiving the live measles vaccine. If they are a healthcare personnel, they're international travelers, even if born before 1957, they're school-age children, or those attending colleges and other post-high school educational institutions, they should receive 2 doses of MMR vaccine 4 weeks apart. If those who need only 1 dose of MMR vaccine, they would be those adults who are born in 1957 or later who are low risk, which means they don't travel internationally, they're not in a community where there is an ongoing outbreak, they don't work in healthcare, they're not attending any college or post-high school educational institutions. Then if they don't have evidence of immunity, they have not received a live vaccine, based on documentation, they have not had measles infection prior, then per guidelines, they need at least 1 dose of MMR vaccine. And those who need 0 doses of MMR vaccine, these are individuals, adults born before 1957, except healthcare personnel. Why do we keep talking about 1957? Again, the vaccine became available 1963. But before 1957, what studies have shown that when they tested people for immunity, almost 98% of them actually either had infection, clinical or subclinical, and showed evidence of immunity. So that's why that year is what we are using. Adults born before 1957, except healthcare personnel, and adults born 1957 or later who are at low risk and who have already received 1 or more documented doses of live measles vaccine, and those who have immunity or those who have had infection, they don't need any further doses. And vaccination in outbreak settings. As I mentioned earlier, the normal age that we give the MMR vaccine or MMRV vaccine is that 12 to 15 months age group. But in an outbreak setting, it is important to give vaccination to those even younger than that. So MMR can be given to children as young as 6 months of age or at high risk of exposure, such as during international travel or a community outbreak. However, doses given before 12 months of age cannot be counted towards the 2-dose series of vaccine, which means that if we give a dose to those as young as 6 months of age, that is not counted when they're eligible to get their first dose per the vaccine schedule at 12 to 15 months and then at 4 to 6 years, which means they just get that additional dose that was given because of a community outbreak or because there is international travel planned to an area where measles is still prevalent. Although MMR vaccine package insert recommends a 3-month deferral of pregnancy after MMR vaccination, CDC and ACIP recommend deferral of pregnancy for 4 weeks. That's because MMR is a live attenuated vaccine. And birth before 1957. People born before 57 have lived through several years of the epidemic, and before the first measles vaccine was licensed in 1963. So that's why most likely they've had measles. And as I mentioned earlier, survey suggests that 95 to 98% of those born before 1957 are immune to measles. And so pretty much we can assume that those born before 1957 are immune. But if we test and see they are not immune, if they are low risk, they should get at least 1 dose of MMR. And if they're high risk, they should get 2 doses of MMR. So presumptive immunity to measles, again, whether either there is lab evidence of immunity, lab confirmation of infection, just saying somebody told them they had measles as a child is not valid. There should be laboratory confirmation of measles, birth before 1957, or written documentation of adequate vaccination, which means either they received 2 doses of the vaccine for school-age children, adolescents, adults at high risk, including college students, healthcare personnel, international travels, and 1 or more doses of measles-containing vaccine administered on or after the first birthday for preschool age children and adults not at high risk. So this is this is considered presumptive immunity to measles. And there is always a concern that, sometimes my patients or their family members share, what are the side effects with this vaccination? What should I be concerned about? I think the benefit of the vaccination is so high, especially for an infection that has no treatment other than supportive care, and an infection that can cause inflammation and the infection in the brain with encephalitis, pneumonias, and hospitalization and death, and also the late complication of SSP, subacute sclerosing panencephalitis, which is almost always fatal. The only preventive tool we have is vaccination. And this is, again, I researched about, okay, what are the things I should be aware of when a child is getting the MMR vaccine? MMR vaccine is associated with a very small risk of febrile seizures, approximately 1 case for every 3,000 to 4,000 doses of MMR vaccine administered. These seizures typically occur 6 to 14 days after vaccination and do not appear to be associated with any long-term sequelae. Children with a personal or family history of febrile seizures or family history of epilepsy might be at increased risk for febrile seizures after the MMR vaccination. And 2 post-licensure studies indicated that 1 additional febrile seizure per 2,300 to 2,600 children aged 12 through 23 months occurred 5 to 12 days after the first dose of MMRV vaccination, compared with children who had received the first dose of MMR vaccine and VAR vaccine administered as separate injections at the same visit. And data from post-licensure studies do not suggest that this increased risk exists for children aged 4 to 6 years receiving the second dose of MMRV vaccination. So multiple studies, as well as a National Academy of Medicine vaccine safety review, refute a causal relationship between autism and MMR vaccine, or between inflammatory bowel disease and MMR vaccine. And if we look at the vaccine safety data here, there's a list of these adverse effects. Fever, which could be the vaccine resulting in mounting that immune response, 5 to 15%, rash in 5%, febrile seizures, 1 in every 3,000 to 4,000 doses for the MMR vaccine, but no long-term sequelae have been reported. Anaphylactic reaction, 8 to 14 cases per million doses. Again, very low number. And arthralgias and other joint symptoms, 25% in adult women. MMRV vaccination, 5% of them developed fever post-vaccination, and febrile seizures, 1 additional, but 2,300 to 2,600 children ages 12 through 23 months. And I mentioned a bit about herd immunity in the beginning of my presentation, and this picture clearly depicts that. You see in the center, that's the patient with the measles. And surrounding are those, if you see the one on the left, with all of them colored red. So those would be those who are susceptible to get the infection. And as I mentioned, one patient who is infected with measles spreads the infection to 9 out of 10 susceptible individuals. So 18 out of 20 almost. So if you see here, again, very easily spreads to others. But then if you have some people vaccinated in the community, but not a lot of them, you will decrease that spread to some extent. That's called the herd effect. But you still see a lot of infection around that person who's infected. They're still spreading to a lot of individuals. But if you have, again, 92 to 94% of those in the community who are vaccinated, who are immune, then if you see here, the risk of spreading to decreases significantly. So, and the risk of transmission is very, very low. So that's called herd immunity. And as I mentioned, we need to achieve that 92 to 94% of vaccination or immune status in the community to achieve that herd immunity. And in Georgia, we're at 88.4% vaccination rate for kindergartners for the school year 23 to 24. And this is overall Georgia, but if you look at the measles cases, most of them are occurring in communities with low vaccination rates. And majority of the cases are occurring among those who are susceptible, who are either unvaccinated or unknown vaccine status. So extremely important to achieve the herd immunity because they're children, right? There's children who are yet not eligible to get the vaccination. There are those who may not have gotten the childhood vaccination, but they can get it now because either they're pregnant or they can get a live vaccine at this point because of other comorbid conditions. To protect those who cannot develop or who cannot get the vaccination, if we have enough people in the community who are vaccinated, that will create a ring of protection around those people who are unable to get the vaccination so that they don't develop the infection. And again, another pictorial just kind of showing the same, that if no one is immunized, just you see just one or two patients with measles spread it to so many others in the community very, very quickly. And then if we have some people at least who are vaccinated, it still spreads to those who are susceptible. But if you see the bottommost picture where you still have patients with measles there, but then there's enough people who are immune by vaccination or prior infection if they're old enough. But there's enough people who are immune with that 90 to 94% of the individuals in that community being immune. Even if those that are susceptible are there, the pictures in the blue depict those who are actually susceptible but cannot get the vaccination either because of contraindication or the age, but they're protected because there are enough people around them who are immune that are not going to get the infection. So they're protected by that ring of people around them who are immune. So very, very important because that's how we're going to prevent the transmission of measles easily in the community. We're going to prevent the spread. And this is again another pictorial depicting the same. The picture in red are those who are contagious, which means they have an active infection. The yellow depicts the susceptible, not immunized individuals, and immunized are in blue. And if you see the picture to the right, there are enough people who are immunized that even if there is a small number of individuals who are not immunized, they are protected because they're surrounded by people who are immune. So, but if in the middle picture, there's some people who are immunized, but not enough. So there is no herd immunity. So there is still risk, and the pathogen will continue to spread, even if not as fast. So that's very, very important that we all work together and focus on education, raising awareness with full transparency of the information about the benefits of the vaccination, the adverse effects, and what the infection can do to our body. What are the complications so that our parents, our community members can make informed decision about the vaccination, because that's the only tool we have to prevent this infection. And what happens if somebody is exposed to measles? Contacts who do not have presumptive evidence of measles immunity, they immediately should be vaccinated, and they're also offered immunoglobulin for measles, or they're quarantined until 21 days after their exposure to the case patient. If immunoglobulin is administered to an exposed person, observation should continue for signs and symptoms of measles for 28 days after exposure, because immunoglobulin might prolong the incubation period. So very important that even after we give the immunoglobulin, the vaccination series is started, they are monitored very closely. And if they develop any symptoms, immediately placed in airborne isolation precautions. And again, what can we do? Stay alert, identify measles infection, get information about the vaccination history, clinical presentation, again, fever, cough, coryza, conjunctivitis first, followed by the Koplik spots, which is the white spots in the mouth, followed by rash that starts head, face, and then spreads down. And ask about travel, ask about any known exposures. Very, very important to get this detailed history to kind of alert us whether it could be measles. So identification, always notify your local public health. If it's a patient that's presenting to the hospital, please notify your infection prevention and control. Even in the outpatient setting, if you have an infection preventionist assigned to your clinic, please let them know, along with notifying the public health. And isolate them immediately. I think one of the most important things I think we should all have in our clinics or ERs is some sort of an alert, a sign that if somebody's coming with fever and rash, they're not sitting there waiting in the waiting room with all the other patients, that they immediately put on a mask, let the front desk know so they can be roomed immediately. Because measles is so contagious, we don't know who else is in that waiting room. They could be a baby that is not yet eligible to be vaccinated. They could be a pregnant patient that has not received the vaccination, or an elderly patient who could not get the measles vaccine because of a contraindication, because it's a live vaccine. So very, very important that anyone presenting to the clinic, urgent care, ED, hospital, that they are not sitting with everybody if they have fever and rash. They should immediately put on a mask and be roomed immediately. And then inform public health always. That way, public health can provide guidance on testing, isolation, and managing patients with suspected measles, and also people who've been exposed to measles. And then testing, it's a nasopharyngeal or throat swab and urine for PCR, as well as a blood specimen for serological testing. No specific antiviral treatment is available for measles. And for testing, always good to send both urine and nasopharyngeal swab for PCR, along with the serology from the blood for IgG and IgM. Vaccine is the most effective and only tool we have to prevent measles. Achieving herd immunity is crucial. And to achieve herd immunity, we all need to work together to improve that vaccine awareness and education, so we can protect those who are most vulnerable and cannot receive vaccine due to age or contraindications. That's all I have. And are there any questions?